Welcome and happy May. We're really excited to have two excellent speakers. And before we get started, we'll have a little introduction from Dakota Brown, Riverside University Hospital. For the May program, we have two speakers, Dr. David Moore from UCSD and Dr. Aaron Seitz from UC Riverside, talking about neurocognitive issues. Before we get started, I'm going to introduce Dakota Brown, and she's got a very brief presentation about her program. So Dakota, go ahead and unmute yourself and share your screen if you have slides, and take it away.
So my name's Dakota. I use she, her, they pronouns, and I identify as disabled. I have two visible and two that are hidden disabilities. I have a hearing disorder, I'm a below elbow amputee, and so on. And Riverside University Health System, aka RUHSBH, otherwise known as County Mental Health, has made it a priority to reach out to certain underserved communities. So they've, as any corporation will do, they've developed some committees, and they have, they're reaching out to the Latinx population, to the Asian American Pacific Islander population. The LGBTQ+ has their own subcommittee, and my subcommittee, which is people with disabilities. We have a total of 10 different ones. So we've got the spiritual community in there, and obviously African American. Anyway, what we are doing in our committees is building relationships and advising RUHSBH on how they can provide services, mental health services that are more welcoming, more transparent, and more culturally and trauma informed. So that, disability, whether you identify as having a hidden disability or chronic illness or identify as disabled, the county would like to hear from you. We have meetings once a month, and we have an ASL interpreter there. And it's just a way for us to get some feedback from you on what the county can do to better service you, how to build bridges, whether you've got trauma in your past that needs to be addressed. And so this is just a way for you to advocate for our population of people living with, whether it's HIV or disabilities. I do some trainings, and it's all about how when we make accommodations for the most vulnerable, that everybody benefits. And in disability culture, they call it curb cuts, the curb cut effects, because once they started making the curbs slope down to the street for wheelchair users, they found that people with heavy carts were using them, that pedestrians automatically head for the curb cut, people with strollers. And there are many instances where they've created something for a vulnerable population that everybody benefits from. Subtitles is an example for the hearing impaired, but if you're at a gym or a loud sports bar, you're probably using subtitles. So I do some trainings. If you have a group that would like to become more culturally informed, I would love to schedule that with you. And there's my email address, bodydiversity@outlook.com. And, I'll make this presentation available to Jeff so that, he can send it to you, or you can email me at that address once. You know what? I'll put it into the chat. Are there any questions for me?
Yeah, I'll repeat the question. So he's asking about emergency room physicians who may not be hospital employees and may not have gotten the kind of training you're talking about. So is there some kind of manual or something so that anybody working in that setting, whether an employee or not, has the benefit of that training?
Absolutely. And you know what? I have the PDF website, and I'll put that into the chat also. And since we work with mental health, I'm not sure if we can train, regular full health practitioners, but I bet we can because it's, behavioral health and it's public health. So I'll look into that, but I will put that, how you can download that training manual into the chat.
Terrific. Thank you so much, Dakota. We really appreciate you joining us this evening.
Awesome. Well, thank you very much for having me. It's really wonderful to be back in person, giving talks. I've been out to this group before, but it's been too long. So good to see those of you that I've seen before. Good to see those of you that I've not met previously. I'm really thrilled to be here and share with you some of our research that we've been working on. I freaked Jeff out today because I sent him a slide deck that had 70 slides in it. About 20 of those were meant to just be there as backup slides, and then I got rid of a bunch more. So I'll shoot for about 25 minutes, and I have my timer set here to remind me. So I'm going to talk a little bit about potential overlaps between Alzheimer's disease and HIV-associated cognitive problems. And this is something that people, at least in the community that I've heard, sometimes are concerned about and want to hear about. At the end, I'll show you some ways that we may be able to thwart some of those potential overlaps. So I'll do my best to share those that info. So I always put this slide at the end. I've learned to put it at the beginning. For our research studies going on at UC San Diego, if you're interested in our research, we're the HIV Neurobehavioral Research Program. The easiest way to get in touch with us is to call. I know that's very old school, but if you call this number 619-543-5000, you can get information about all the different studies we have going on. We usually have between 10 and 30 studies that are enrolling. And you may or may not qualify for any of them, but you may qualify for many of them. And for some of them, we do provide transportation from Palm Springs. So be sure to ask about that as well. And we are doing some of our assessments virtually via Zoom. And then there's certain assessments that we have to do in person. So we're doing some of our cognitive assessments over Zoom, and then things like blood draws and LPs, where we do lumbar punctures and get CSF for some studies, obviously need to be done in person. So I think people have probably seen this before, but it is important to remind ourselves that over half the people living with HIV in the United States now are over age 50. And you can see the other bars there. We have 102,000 people in the United States who are over age 65 living with HIV. And so looking at people and trying to understand people who are older and living with HIV is a real priority. And many of you may also be familiar with this term HIV-associated neurocognitive disorders, or HAND. There was a really recent review that looked at all the studies across all the literature and tried to look and see how often does this occur. So this is mild problems in at least two domains of cognition, 2 domains of thinking skills. And we have these different breakdowns with asymptomatic neurocognitive impairment, which is this ANI one right here, severe no daily functioning problems with that one. And then we have MND, mild neurocognitive disorder. That's mild problems with cognition plus some daily functioning problems. And then the most severe one, which is HIV-associated neurocognitive or HIV-associated dementia. And so this was a really broad study that looked at all the different studies to see how often this occurs. So I'm happy to talk about that later as well. And then there is a question that how often do people who are living with HIV end up with Alzheimer's disease? And Alzheimer's disease is a condition that many people are aware of. It's a progressive cognitive decline, and it occurs in roughly about 10% of people age 65 and older, 35% of people age 85 and older. So it is a really common condition and one of the major public health problems that we face in our country. And so people with HIV may be at higher risk for Alzheimer's disease, and that's one of the things that we're studying and looking at. And one thing that we're really, really focused on is trying to understand who may have the HIV-associated cognitive problems and who maybe has the Alzheimer's disease cognitive problems. And right now, it's kind of a mix and match. It's really difficult for people, clinicians, to be able to say what's going on. So we've been trying to better characterize those differences. So a lot of what I'm going to talk about is those differences. How do we find out someone who may have hand versus Alzheimer's disease? And one of the ways that we're looking at this is to look at what we call amnestic mild cognitive impairment, which is one of the precursors or the things that happens before Alzheimer's disease. And it's really focused on a memory problem, an isolated memory problem. That's what AMCI stands for here, this term right here. And it often leads to Alzheimer's disease. So it's important to recognize that. And here is just a rehash of the prevalence of Alzheimer's disease. This is not people with HIV, but you have men down here. You can see if we all live to be 100, about 30% of people will have Alzheimer's disease. If we all women live to be 100, about 35–40% of people will have Alzheimer's disease. And it's a little bit different than the numbers I showed before, but the reality is there's been people who've said if you live long enough, everyone will get Alzheimer's disease. And this is based on the accumulation of certain deficits in the brain. So here we have these two kind of conditions, and these are a bunch of fancy terms for thinking skills, attention skills, motor skills, like putting groove pegs into a board. These are like solving complex problems. And then in hand, we also have these episodic memory problems, which is really the key component of AMCI and that diagnosis. So we have this little schematic over here. We have people who have normal cognition, not impaired cognition. We have people who have hand, and then we have these people who have these isolated memory deficits. And so how do you tease these two things apart? That's really what our research has been focused on recently. And you can see here that an AMCI or a recall problem, people would have a relatively steep decline if you have Alzheimer's disease. Most of the time, people who have hand may have a waxing and waning, and it's not typically progressive. So most people who have a mild cognitive problem with HIV, it mostly stays mild throughout the lifetime. So that's really important to remember. There are some people who decline, there are some people who improve, but most people have a stable, mild impairment. And that's different from Alzheimer's disease. And so we're trying to capitalize on those differences to see what's going on. One thing that is true is that people with HIV have some shared risk factors that people with Alzheimer's disease can have too that make it increased risk. And so these are things like advancing age, vascular problems, mood problems, and then ApoE genotype, which is a gene that puts people at risk for Alzheimer's disease. So that's not necessarily increased in people with HIV at all, but if you do have that risk factor, that's something we can look at. So what's the significance here? Why do we care? The most Alzheimer's disease interventions sadly have failed. And that's because most likely we're looking too late in the disease process. So we need to look earlier and earlier and earlier in people's lives to be able to identify what's going on so we can stop the progression. The same is probably true for people with HIV and cognitive problems, so that we want to get earlier interventions, sooner interventions that can to prevent the progression or even the incidence of cognitive problems in people with HIV. And also, if we can tell people, hey, look, you have hand, you don't have amnestic mild cognitive impairment, you don't have Alzheimer's disease, I think that could alleviate a lot of fears that some people have about their cognition. So that's the purpose. So we have this grant from the National Institute on Aging that's really trying to disentangle these two things, this amnestic mild cognitive impairment from hand. And so this is our schematic. Again, if you look down here, we're trying to pull out those people who have amnestic mild cognitive impairment, which would be more like Alzheimer's disease, and see what's different about them. So we're capitalizing on certain methods to do that. Here, I'm going to tell, for those of you who've been involved in our studies, you may recall there's a list learning test. I might read you a list of words, and I say, tell me back all the words you can remember from this list. And then you do it once, and then I tell it to you again. And I say, tell me back all the ones you remember now. And then I do it again, tell me all the back. That part of the test is the learning part. So if I give you additional exposures, if I repeat the information over and over again, can you learn more information with each subsequent exposure? That's learning. And then we go and do some other tests, and we come back 30 minutes later and we say, what were all the words on the list? That's the recall portion of it. So the remembering part of it. And then the last part is I say, okay, was apple on the list or zebra? So I'm really saying just two things, and one of them was on the list and one of them wasn't. And that's recognition. So can you recognize which word was on the list or not? So those three components of that type of test, we're really leveraging the differences between what happens in people with HIV and what happens in Alzheimer's disease. So in people with HIV, they rarely have problems with recognition. So if I say it was apple or zebra on the list, almost all the time, people with HIV will get that correct. People with Alzheimer's disease or amnestic mild cognitive impairment often have problems with recognition. So it's a real differentiating point that we can use to try and find people who might be at risk for Alzheimer's disease and people who are not. So that's kind of the methodology that we're using here. So we use that. I'm going to just say, so this criteria really capitalizes on that recognition component. And then we classified people into, are you in a hand plus AMCI group like this? Do you have both conditions? Do you just have AMCI and not hand? Do you have hand but not AMCI, or do you have neither condition? So cognitively normal. So we're basically just grouping people into these cells. Which do you have? And then a bunch of fancy statistics that I don't even understand that our statisticians do, and we can plot the trajectories of people over time. And so these are just those four groups again. So here's the people who don't have either condition. What do they look like as they move from age 45 towards age 75? Well, these people, everybody shows a little downward slope, which is what you would expect. People are aging, they're not doing as well in these thinking skills tests. What we hypothesized was that anybody who is in the AMCI group would do the worst. What we actually saw was the people who have AMCI alone have the steepest decline. So not AMCI and hand, which is kind of interesting in that the thing that is classifying people as AMCI and the dually affected group down here, they start the lowest and they kind of stay the lowest, but they don't go as steeply declining. And we're trying to figure out why that is. And this is true. So this is learning. So I give you repeated exposures. How much can you learn? This is recall. How much do you remember over 30 minutes later? And this is recognition. Okay, so what goes down over time. We then looked at, this is just to show you that, we're plotting these lines, right? Each one of these little plots here is actually an individual averages, and often the individual is not representative of the average. So it's really important to remember that. So this is each one of those cells again for learning. We have it for recall. Again, we can see the steepest in the AMCI group only over time, and then recognition, over time. Okay. So I just want to show this just so you can see these individual lines that represent individual people. And then here, we just pulled out 3 representative case examples. So you can see, so here, this is just for learning again, and we pulled out a stable female, age 57, 14 years of education, white, on therapy, has been diagnosed with AIDS, and her performance looks like this, pretty stable over time, right? We have a decliner here, a male, age 57 at baseline, 17 years of education, white, on therapy, has had AIDS, right? And you can see that around age 57, and then by age 70, they've gone down quite a bit. And then we have an improver here, age 52 at baseline, and then over time they get better. So trying to figure out each individual and what are the factors that help them in each of these categories, or what are the factors that put them at risk. Okay, I have 8 minutes left. I'm going to skip this part, other than to just say that this is kind of how brain pathology looks in Alzheimer's disease. So if you just look at this blue part, you can see some changes going on in the brain, maybe 20 years before an Alzheimer's disease diagnosis. And then you see a little bit more, maybe 2 to 10 years, and you get this much more significant pathology, maybe 1 to 5 years. So there is a progression of the pathology over time. And to say that those typical Alzheimer's disease markers that we're looking for in the brain, when we use our classifications of AMCI, so an indicator that you're going to have Alzheimer's disease, versus our classifications of hand, when we use those AMCI classifications, we can actually see those markers in the brain. So using your performance on those tests, we can predict who will have more Alzheimer's disease pathology after they come to death. Yes, question. Yeah, so like in events like this, yes, and you can get feedback. So you can request feedback, and we'll give you specific feedback. So so you can request feedback directly getting feedback. So but mostly in presentations, but you can get individual feedback. The challenge with that is sometimes people use that as clinical evaluations, and we don't do a thorough interview with people to look at all the other factors that might be going on. But yeah. So the question is, do we give individuals feedback on their performance while they're on study? And would we tell someone whether they're likely to have Alzheimer's disease or not? Probably not. What we could tell you is what the tests in each of the domains looks like, and we could say your performance on the memory test is concerning. We would suggest you go see your doctor and tell them that, and ask for a formal clinical evaluation, because there's a lot of other factors that we measure, but we don't do a full clinical workup like your physician would do. So, but certainly you can get asked for feedback, and we'll give you feedback that you can take to your doctor. So if that makes sense. You're welcome. So here I'm going to go through this quickly, just to say that there are markers that can come from your cerebral spinal fluid, which also indicate Alzheimer's disease, and those things also relate to these 3 areas of learning, recall, and recognition. So we can see that in our findings too. So what other ways can we pick up whether someone might have Alzheimer's disease in the context of HIV or not? We've recently used smell tests, and with COVID, this has gotten a lot more attention than it was with HIV, but we were already doing this work before people saw problems with COVID. And the reality is, olfaction scores, we can differentiate these groups on the AMCI. So these people would be at risk, based on your score. The people who have high risk for Alzheimer's disease have worse olfaction. If we just look at the HIV-associated neurocognitive problems, we don't see the difference. So again, the smell test seems to be able to pick out people who might be at risk for Alzheimer's disease. Okay, and this one also shows that those olfaction or smell tests relate to people's recall tests on a 1-week recall test, which was something different. We called people back 1 week later. So often when I give this talk, people say, well, that sounds horrible, David. Thank you for sharing that. So, but it's not all bad news. And so there are some recent publications and things that we've done from our group, which show that basically here, this is related to quality of life. So the more fruits and vegetables you eat, the better your quality of life. The more minutes of physical activity you have, your better quality of life. We have an intervention that's a text messaging intervention. It's a 6-month-long study, which is basically designed to get you to walk more. Has a lot of components to it, has a Fitbit that tracks your steps, as well as this text messaging promotion part. There's also an arm that teaches you how to eat a Mediterranean diet, including giving you walnuts, which are good for you based on the fatty acids. So that is an ongoing study, and we're excited to see what it might show. You get feedback on your exercise, you get diet or recipe recommendations. You can also monitor things like sleep via the app. And this is just examples of some of the goals that we set up for people and what the text messages look like. And these are just data basically showing that in our early formative work before we started doing the longer study, that basically we saw differences between the control group and those who got this intervention. So quality of life, basically this slide is just to say that it is important to consider other things. So we have nutrition, we have physical activity, but also these things like resilience and personal mastery, which I have defined here. Individuals feel in control, that's personal mastery. Emotional support, feeling, the ability to offer empathy to others actually make you do better in terms of your quality of life. Being resilient, being able to adapt to stress and trauma. I think those factors tend to ameliorate some of the problems that people see in quality of life. So that was the results of that. So I'm relatively on target here. So in summary, there are some factors that put people at risk for Alzheimer's disease and its precursor, the pre-stage AMCI. And we're starting to see what some of those are and be able to identify them. And we're hoping to be able to pick these things out, and we are working to get these things more into clinical evaluations, like the smell test. That's something we've been trying to work on, getting our clinicians to use more often. And then, even though we know those things, there are interventions that can help. So nutrition, your mom was right, you should eat your fruits and vegetables. Physical activity, you knew this already, but the evidence is there that additional step counts and things like that will help you slow decline in terms of cognition. And some of these positive psychological factors, things like resilience and personal mastery and high levels of emotional support, can really help quell and improve people's quality of life. And so here is this again. If you're interested, again, please call this number. And I'll leave that up. I'll quickly show that there's a ton of people who are involved in this work. I didn't name all of them. Aaron Sunderman, the Alzheimer's disease work, is a junior assistant professor working with me who did a bunch of the work that I showed today. And then my trainees who I listed here also contributed significantly. And we have funding from the National Institutes of Health and large that support this work. So I'll go back to here, and I'm happy to take any questions. Yes.
Any mix and match study between long-term HIV survivor and long-term stroke survivors?
I'm sure there is some work, but we have not done that work. So what we have done that I'm aware of is there are indications in people with HIV that the brain vasculature, that the small vessels in people with HIV get somewhat disrupted. And that probably puts people at risk for stroke. And it's really difficult then, once people have a stroke, to be able to figure out what was the root cause of that. So sometimes people who have strokes get excluded from studies of HIV because they say, oh, well, the stroke is going to accommodate or is going to account for the cognitive problems that you see. But I think that's short-sighted to some extent, because we know, again, from some of our work, that that HIV can cause changes in the small vessels that are in your brain that supply the blood to your brain. So so that it's a tough thing to study, because once someone has a stroke, then it's difficult to see what the HIV effects might be. I don't know if that answers your question.
Yes, thank you.
So we're going to have time at the end for more questions. We'll take one more question, but then we'll get to Dr. Seitz, so we have time for everyone.
Have you done any research on the older people starting to shuffle their feet instead of walking normally?
Really great question. So the first question was about stroke and cognitive problems, and I said that unfortunately it's difficult to tease those out. The last question was about shuffling your feet, what we call slow gait speed or problems with frailty. We've done a lot of work on frailty, of which walking speed is one of those, and that seems to be highly predictive of problems with cognition. So walking speed is one of the biggest predictors of problems with cognition. So that's why some of these walking interventions may help with cognition. Good question.
Great. Well,
Okay.
thank you so much.
You're welcome.
Great presentation, and we'll have time for more afterwards.
Hi, pleasure to be here. And so I think I'm here partly to show maybe some optimism in terms of certain things that could be done that we're hopeful can benefit cognition. And so my name's Aaron Seitz. I'm the director of the UCR Brain Game Center for Mental Fitness and Wellbeing. And actually I brought a couple guests, Audrey and Morgan back there, that if you want to meet them, they might give you a free pen from the Brain Game Center. But basically they're the people who do all the work. And so the thing that we're working on now, so we actually do a lot of different studies. So we have some studies training vision, some training hearing. Today I'm talking about a study that we're launching that's training working memory. And so what working memory is really your ability to kind of process information over short periods of time in your head. So we're looking at like a few seconds. And that the idea is that, for instance, if you're listening to me right now, I tend to speak in complex sentences. You need working memory to kind of relate a word that at the end of one of my sentences to the beginning to figure out what I'm saying. If you're doing math problems in your head, you need to manipulate numbers and pretty much everything that we do that involves memory first goes into our working memory, which is how we process information. And then hopefully it goes into longer term stores. So, the word list that Dave was talking about earlier, that's considered to be a long-term memory test. If you can remember something for 30 minutes, it means that somehow it made it through your working memory into your long-term memory. And then when you recall it, it actually has to come back into your working memory so you could report it. And so this is an area that is one of the big targets of training, just because it's really how things enter and how things leave your memory or re-enter your memory. One of the things that always seems to be with these slides is we show that things get worse as you age. Memory, is one of these big complaints. I think we all know that our memory is not what it used to be. And this is true both of our long-term memory, that I show the slide of the left, and then also working memory, which I show in the middle. Some things do get better with age. So our vocabulary increases, generally our knowledge, so we know more than kids these days. And so, there are some things, but generally our memory is not getting better. And so, as I said, like at the Brain Game Center, our focus really is to do research where we kind of develop, test, and disseminate approaches that are trying to benefit processes like memory. And our real goal is to try to kind of get out of the trap of just teaching to the test. So one thing which has been frustrating for a lot of people who have tried some sorts of cognitive training is that you get better at what you're being trained on, and it doesn't necessarily benefit your daily activities. And this actually, is probably going to be true for some of the participants in our studies, and hopefully not true for other participants. What we're really trying to do as a research group is try to figure out what are the things that actually will give transfer effects, what will benefit your real life, and then also try to work out what are the things that don't, and especially how this differs across individuals. There's lots of these working memory training games that are out there. Some are targeted to kids, some are targeted to older adults. Actually, bottom left, that's one of the video games that we made for this. I think the bottom right one, I think that's Lumosity. And so there's some studies in older adults. So this is one that basically is looking at how spatial and verbal working memory can improve across, in this case, about 20 days of training. And so, there, are some signs of hope with these. And, the general thought, which I want to suggest, is that this type of training actually has great potential, I think, to improve memory. The big challenge, though, is that not all these training approaches are the same. And that right now, as researchers, it's not entirely clear, what are the active ingredients. So we have a bunch of approaches that we're trying in our studies that we're hopeful to get them to be more effective. But the other thing is not all people are the same. And actually, one of the things that is becoming increasingly clear in our research is that for, two different people, what training approach might be best for them might differ. And we're designing studies, including one of the ones that we're recruiting for now, where we're actually having people train on, each person will do 2 different types of working memory training. And our expectation is that for each person, the one that will be more beneficial for them will be different than for somebody else. And we're trying to see whether we can understand these differences and maybe even be able to predict them based upon some of the cognitive tasks similar to what Dave had presented. But the key thing is that, research is really needed to figure out, who's a good candidate for working memory training. And then also, how do we personalize the training to different people? Going to aging and HIV, this is actually a new area for us. Actually, we're fairly new to interventions in older adults as well. Part of this is because we spent a bunch of time working out some of the methods with college students as guinea pigs. And, if it's not working well with them, then we're not going to waste other people's time. But I think that we've grown as a center and that we have approaches that I think are, competitive or sometimes better than some of the things you could buy commercially. And really the things that we want to do is, the first half actually is very similar to what Dave talked about earlier, is that we have a lot of different cognitive assessments. Some of them are new ones that we've been developing that we think actually might be sensitive, more sensitive than some of the neuropsych ones. And individual trajectories of people who are aging with HIV and how those might differ from people who are aging without HIV. And then the other thing is the training side, where we have these different training interventions, and that we really want to understand, across individuals, how are these beneficial or not? And then also, what are some of the things that might be different in people aging with HIV? Because, I've seen some studies where they've done cognitive training in people with HIV, but I haven't seen studies that do comparisons to try to understand, what might be, either some of the different individualized needs or different population needs. And that this is something that we really want to be able to understand better. And I think it's necessary to be able to have better interventions. One thing I should learn from Dave is that I should put my slide at the beginning and at the end, but we'll share kind of this link. Also, we have some flyers for the people who are here. But if you sign up at our webpage or send us an email, we're really looking for participants, and also we're looking for partners. And we also can make it easy to participate in studies, so we could lend people tablets. You could do most of our studies in your own home. We could, even have data plans with a tablet, so that you could basically get a tablet, click a button, you'll be on Zoom with one of our personnel, maybe Morgan over there, and then walk you through the different procedures. And so, please, sign up, and I think this could be a really good collaboration. I think that's it.
Yeah.
Mine's short.
Terrific. Well, thank you so much.
Yeah, no, in fact, actually, we have grants pending to look at some of the same training approaches that we're using in older adults with people with ADHD, and there is a research literature on both the working memory training that I kind of mentioned as well as some others, and the research is mixed. And so what's really unclear is whether it's that different people with ADHD are getting different outcomes, or one thing actually with kids with ADHD, one of the biggest issues is compliance. I mean, you might kind of remember, the extent to which you would follow through with all the interventions that, your parents or teachers might have gone through. But basically, actually we have a grant where we're trying to look at how to use different motivational structures so that we could, take the same active ingredients, but see what does it take to get somebody who, might not have the motivation to complete the training to actually finish it. But I think that's one of the challenges, is that there's lots of exciting demonstrations. In fact, there's a company, Ikili Software, that has I think it's EndeavorRx, is now FDA approved brain training program for ADHD. But it's still kind of controversial because I think of these individual differences that I think are not super well understood. And so I think that there's promise. If I were you, I think it's worth trying some of these things out. But I think just like anything that's self-help, there's a little bit of buyer beware that's also important as we're still working on the research to kind of improve it. So once again, there's a lot of individual differences. I think there are some people who get benefits. There's other people who are overwhelmed with side effects. And it's another thing where, I've gone to psychiatry department meetings, listening to psychiatrists talk about how to get the right mixture right for different patients, and it seems almost like cooking, trying to kind of find what is the right mixture for a given person. And I think that so sometimes these can be very helpful. But it's also complicated. I don't know if you want to add.
Yeah, I'd agree with that. Certainly there are people who really benefit from some of the psychostimulants who have ADHD. And I would just echo everything Aaron said, that certainly there are some trainings that will work for some people and some that don't. And not every ADHD, just like every, I showed those different individuals, right? And we're showing these mean lines. So each individual is different, and what works for one individual may or may not work for another individual. And I will say that in our studies in San Diego, having a diagnosis of ADHD doesn't exclude you from participating. In fact, we have a lot of participants who have ADHD, and we look at those factors when we're looking at our outcomes to see if they may impact the results. So, just as a informational. Yeah. There are differences in terms of the.
How do you know if you have either one of those?
So so the question was, how would you know if you have ADHD? Certainly you may have certain symptoms, difficulty paying attention, difficulty concentrating. A lot of times people have certain habits they develop, like, leg shaking or having a hard time staying in their seat in school. So people often get identified, and there's a host of different outcomes for that as well. One interesting thing I've seen about ADHD is the free roam classrooms. I don't know if anyone's seen this, where they allow students, they don't have to stay in their seat. If they have ADHD, they're allowed to wander around, and the outcomes are much better for the students when they're, they actually can pay attention and wander around the classroom. So, and it's actually not good for you to force someone who has ADHD to stay in their seat. So they actually do better. So allowing these free roam classrooms, allowing students to learn in a way that works for them, I think is important. I don't know if you want to add to that.
You're just making me self-cautious about my fidgeting.
Really good question, and I did go quickly through those, and I probably should have deleted even more slides in the spirit of Aaron's set. I didn't get too much into the mechanisms, but there is evidence that HIV basically can cause this storm. It doesn't directly infect neurons, but what it does is causes an inflammatory cascade. So you get a little bit of inflammation in your brain. And basically there are factors then, depending on which things you're looking at, it creates a little bit of a inflammation situation. So if you think about when you have a fever, right, that's a little bit of an inflammation situation. And what seems to be potentially happening as one of the mechanisms is that in long-term survivors with HIV is that you might have chronic low-level inflammation. So in the early phases of the pandemic, the HIV pandemic, we had people who were not getting treatment and they could get really severe cognitive and psychiatric problems. And that was probably because they were getting really severe inflammation. And now with effective treatments, that really quells the inflammation, but there probably is just a tiny bit of low-level chronic inflammation that goes along. And that may lead to some of the degradation of neurons. I didn't show this graph, but if you look at some of the markers of Alzheimer's disease, things called plaques and tangles, that's the way they diagnose people with Alzheimer's disease. It's really, the diagnosis is only made after death when they look at people's brains and they look at for these markers. And if you look at someone who never had HIV, you look at someone who had HIV and you look at someone who had Alzheimer's disease, I'm going to use my hand, which is probably not good for Zoom, but you know, if you did not have HIV, you kind of have this really low level. If you did have HIV, you have just a little bit more, and in our science world, it's statistically different. So it is more than you would find in someone who didn't have HIV on average. But then you look at someone with Alzheimer's disease, and it's like tenfold more. So it's like here, here, and here. So there is something going on that may put people at risk for having more of these plaques and tangles in HIV. And there's been a bunch of studies that have shown that, but it's not like it puts you at the same level as Alzheimer's disease. So I think that's really important for people to recognize. But because of that, you may be a little bit more risk for getting Alzheimer's disease, or people may have a predisposition, they were going to get Alzheimer's disease regardless of whether they had HIV or not, and maybe those problems start to manifest a little bit earlier, if that makes sense. So your family history of Alzheimer's disease would be 3 of the slides that I deleted before in my quest to get fewer slides. So we have looked at that. You know, it does put people at additional risk who are living with HIV, and we've looked at that. One of my doctoral students right now is looking at the ApoE4 gene, which is a known gene that puts people at greater risk for Alzheimer's disease. So it's really, it's difficult, you know, because people who have, say, vascular problems, we know people who have vascular problems have increased likelihood of having problems with their cognition. And we know that HIV can increase vascular problems. So we do try and account for, we call them comorbidities, these other health conditions that are existing. We still do, even when we account for those things, we do see still an effect of HIV. But you know, we try our best to account for all these different you know, cofactors of comorbidities that people have. When it comes to things like Alzheimer's disease, we are looking for specifically for that, and we evaluate family history of dementias, any type of dementias. We used to just ask people, you know, has anybody in your family ever had dementia? And then in one study, we do this very detailed characterization of people's family history of dementia, where we say, okay, your mom, how old did she live to be? Did she have any of these conditions? Well, XYZ. Your dad, did he have these conditions? So we really go through when we're looking for, specifically in our Alzheimer's disease overlap studies. I hope that answers your question.
So how does this kind of track with what you've seen, Dr. Moore?
Yeah, so the results are pretty consistent with what I would have guessed before we started. Some things, like having people show you things rather than tell you things, it is easier for most people to have things shown to them than told, but it's about frequency, right? So is it all the time that it's easier for people to show you things than it is to tell you things? And that can be potentially difficult and indicative of maybe a more significant dementia. Some of these other things, like naming everyday objects, so things, and one thing that's not in here is often we ask, is this a change for you, right? So is this a new thing for you? So, all of us have what is called the tip of the tongue phenomenon, where it's like, oh, I know the word, I've got it, and you can't quite pull it out. But the frequency, again, how often is that happening? So if you're having difficulty naming everyday items almost all the time or all the time, that is concerning for a more prototypical Alzheimer's disease type diagnosis. So some of these, it's really about frequency that things are happening, plus whether it's a change for you. So, and some of these may be more indicative. To get a diagnosis of a dementia, you need to have a problem with your memory. Alzheimer's disease, one of the other things that is frequently comes up is this naming problem. So people can't think of names for, again, everyday objects that they might use. And often you'll see people who are having difficulties in the space use what I call the superset word. So, if you want a spatula, you just say, pass me that thing, right? So it's not that you aren't going to say anything, it's just, pass me that thing. And you'll see people make the motions too. And so you can see that naming difficulty as people get more progressive Alzheimer's disease type dementias and some other dementias or conditions. I don't know if that's helpful. So it's more, it's not necessarily forgetting spatula more than once. It's just general things that you would have previously known the name of, and now you can't come up with the name for it. And I think it's really, that advanced planning is so important. And unfortunately, as I'm not doing active clinical work, but I am a clinical psychologist, and it's one of the most difficult things to see is when people start to have cognitive declines and they haven't made plans for how they want their affairs handled. So I would encourage everyone, and people say, well, I don't care, or I don't really have anything that people would care about, or all these things. Like I will say, personally, I disagree, right? It's always helpful to have those things in place. And unfortunately, yes, not everybody, but cognitive problems as you really get into older age are really common. But I didn't show our work on superagers, but there are a subset of people who seem to really be able to thwart any type of cognitive problems, irregardless of their age. And that's another, a talk for a different day, but it's fascinating.
So, the general, so both yes, but the general advice that I would give is that you want to continue to do things that keep your mind active. And so I think brain games are kind of one method of doing this, but I think that, it seems to be the case that once you get good at something, you probably want to choose something that you're not good at and start practicing on that. And so one of the things that we try to do with the games we're creating is make it so that they measure what you're good at and provide challenges that make it so however good you are, it's going to be that much harder. But, as an intuition for anything you do in life, if you keep on trying to acquire new skills, you're doing the right things that are going to promote healthy cognitive aging.
If I could just add to that, I 100% agree with what Aaron said. So, it used to be 20 years ago, people said, oh, you should do crossword puzzles. Crossword puzzles and you won't get dementia. And then you have people who do crossword puzzles every day and they get excellent at it. And the reality is exactly what Aaron just said, which is you want to increase what we call the plasticity or flexibility of your brain. So if you're doing Wordle every day and you're great at it now, you should switch to the Nerdle, or you should do learn a new language. Try them if you've never played a musical instrument. I don't care if it's, Mary Had a Little Lamb on the piano, go and try and do that. So those are the, pushing yourself, go try and learn a new skill. That seems to be one of the really important things. And then, as I had in my last, one of my summary slides there, good nutrition, physical activity. Physical activity, people tend to separate their, body from their brain, but the physical activity for the brain really helps perfuse the brain, so you get your blood flow. It helps get rid of a lot of toxins that might be in there, not good for your brain, so that seems to be good. And then just emotional well-being as well seems to be really helpful for people. And these things are not siloed, right? All these things are holistically helpful. Some of Aaron's brain training is, an excellent idea as well. So any of these things can be helpful. And some may work better for some people, probably not. It's probably just general, I think that, taste buds go down, unfortunately, with time too, and most people, as they age, they eat spicier and spicier food, so.
Well, you did mention olfaction, so smelling, the taste of smell and taste are very closely related, so could that be?
Correct, yes, for sure. Olfaction seems to be a little bit more sensitive to the problems than taste. So, and certainly there are, and Aaron knows a lot about this too, hearing is another thing that it seems to be that as people have hearing loss, then their cognition goes down, and that may be just, again, if you're challenged to hear all the words that people are saying, you're probably not challenging yourself cognitively as much as you were when you were hearing all the words. So you're just kind of getting the gist of the message rather than the complexity and nuances of the message. So that may be part of the hearing loss cognition relationship, and or you have to focus so much to get the content based on the hearing that you lose the subtleties of the conversations that are going on. So, these sensory impairments are really interesting and how they relate to cognition.
And maybe one thing I'll add is that there's a lot of thought that, actually both with hearing and also with vision, that one of the things that contributes to is a reduction of social engagement. And that social engagement is something that is very positive towards, healthy cognitive aging. And so everything kind of interacts. And so, I think we wish we could say, hey, do my, brain game and it's going to solve everything. And I think the reality is think holistically that kind of all the advice people give of, being active, eating well, being socially engaged, doing new challenges, the more of this you're doing, it kind of addresses some of the individual differences, because maybe for some people one of these activities will be much better than the other, but the more you do, the more likely that some of them are the things that you need. And that's where we kind of are as scientists. The answer, once again, is going to be depends, right? Sometimes, something that is mindless can be, zen. I mean, so basically, if it relaxes you, then that could be helpful. If it pulls you away from activities that would otherwise be beneficial, then it's not. So, slot machines are a great example where, if you just did it for, 5 or 10 minutes, fine. But if you're there for like 4 or 5 hours and it basically, besides whatever financially it might do to you, that you made a choice that you're going to do this mindless activity as opposed to other activities that could be stimulating. That's the place where there can be harms. But it's very particular to the details.
So on that topic, you can see people, I know people who it's like they got into Candy Crush and they're sitting there doing Candy Crush, over and over and over and over and over again. That gets you a little bit towards the addiction side of things, if you're really doing this over again. So there are parts of our brain that, the reward pathway that is drug abuse, food overeating, sexual compulsivity, gambling, those can reinforce one another. It's the same parts of the brain that get fed in those things. So there's some reinforcement that people are getting from doing that. So it is something just to pay attention to, slot machines versus Candy Crush, one may make you broke and one probably just keeps you disengaged, as Aaron says. So there are different levels here, but it can get, in this reinforcement pathway. And it may be, like Aaron says, it's a good escape, but if it's keeping you from other things, then it has an impact on your daily functioning.
Thank you. So you mentioned drug use, and every other week we're hearing a different study that alcohol is good for you. It's good for your heart, your cardiovascular system, and then it's bad for your memory. It's terrible for you. It kind of seesaws back and forth. And then, of course, with cannabis becoming legal, a lot of people with HIV have been self-medicating a lot of things, both physical and anxiety and sleep problems, as well as like pain, neuropathy, things like that. So how does that all play into this, and how do you control for that when you're doing your research?
Yeah, so Jeff's good for the tough questions. Thanks, Jeff. I could go with the simple answer, which is everything in moderation, right? That's one possible answer. The other thing that I'll say is all drugs, I'll put alcohol in a drug category, are not created equal, right? So they have differential effects. There's evidence in healthy aging that one drink a day may relax people and keep certain people from being too stressed and they're okay. There's other things that say, oh well, the teetotalers who don't drink at all do better. A lot of those are probably relatively small effect sizes between those. Those are huge studies. So the one-day drinkers versus the no drinkers, we're probably splitting hairs there. But one thing we know is that if you exceed the recommended amount, whether you meet criteria for alcohol abuse or dependence or now alcohol disorder, that's not good for you, right? So that's pretty clear. So that's like 4 or more drinks a day for men, 2 to 3 drinks a day for women. I can't remember all the criteria, but drinking a lot. So I think it's less about the is it none or 1 a day, and more about those people lumped together versus excessive drinking. So that's alcohol. Cannabis is really, really interesting, and we have a whole center at UCSD, the Center for Medicinal Cannabis Research. There's different active components in cannabis. There's the psychoactive part, which is THC. There's cannabidiol, which is not psychoactive and seems to be really helpful for pain. And I guess from, this is my personal opinion, and the data seems to support this, is that, prescription opioid abuse is a major problem in the United States. And there's good evidence that cannabis products that are high in cannabidiol for things like pain relief are just incredibly safer. And that's, I think, important for people to recognize, that, and I think we'll move more, my guess is that people will move more towards that as things go on, because, opioids are extremely addictive and they're extremely dangerous. And cannabis, on the other hand, does not have those same dangers, even though it's been, up until recently, illegal. So that's part personal soapbox, but also, I think, really important to say.
Maybe I'll just add that, research for things with cannabis, is still evolving. So, a lot of the studies have been done with lab grade cannabis, which is not actually the same thing that you would buy. And there's some studies that I reviewed that are looking at essentially different cannabis that we bought that has different ratios between THC and CBD, and some of those ratios are ones that don't seem to give a lot of cognitive impairment, others quite a bit, in terms of you're actually on use. And so this is where it's really complex, because, I think with any drug, it's not just what drug you're doing, but the particular type of that you get. And, also the research, is way behind the reality of the things that people know of themselves.
Yeah. Yeah, Aaron brings up a really good point there, which is that right now, and I'm not sure, up until the very recent past, in order to do research through the National Institute on Drug Abuse, which is where most of this comes from, you had to get your cannabis from a dispensary in North Carolina where they grow it. And you're just getting this cannabis, right? You're getting their cannabis. And you can walk, within 2 miles from here and walk in a dispensary and get 20,000 different choices of how much THC and CBD content you want. So to say that the research lags is somewhat of an understatement, And I will say at one point we had a very ambitious junior faculty member who, he really wanted to go buy drugs on the street, and he wanted to do, cultures. He did basic biology work, and he wanted to look at real meth that you could get off the street. What is it cut with? What's in there, and how does it affect these certain brain cells? And he tried and tried and tried, and no luck. Right, so that kind of real world versus what we can do as researchers, is, especially as it relates to substance use, is a challenge.
Yeah. Well, thank you. We're at the top of the hour, so thank you again, Drs. Moore and Seitz. This was terrific. I appreciate the fireside chat.
Yeah, thank you very much.
And thank you all for coming, and we will see you next time.